Hello everyone, so my name is Anita. I'm a registered midwife in the UK, and today I would like to take you through the assessment station of the midwifery OSCE. So the assessment station, we have a structured marking criteria that each and every one of us, or each and every one of the candidates, needs to follow in order for you to pass your midwifery OSCE, and how you are supposed to illustrate all those points that can help you pass your OSCE. They are going to mark you based on the marking criteria. So if you miss a step which is supposed to mark you down, then that means automatically you're going to fail your OSCE exam. So you need to make sure that each marking criteria has been taken care of. So with the assessment station, you are given 20 minutes to finish the whole process, and that involves your communication with the patient or the mannequin over which you're going to meet. You can meet a patient or a mannequin, either of that, and your documentation and your handover. So within 20 minutes, these are the 3 things you need to follow. If you miss your handover to the examiner, that is considered as the multidisciplinary team, that's the MDT, you are going to fail. So you need to make sure that you have done your assessment of the patient, you have documented correctly, and you have done your handover. These are the 3 things you need to consider in your assessment station. So always have it at the back of your mind that with your 20 minutes, these are the 3 things I need to do in order for me to pass my assessment station. So with the assessment station, you are given a sheet which has a scenario in it. So it could be vaginal bleeding at term, or it could be abdominal pain, or definitely it has to be a pregnant woman, because you are a midwife and you need to assess the woman from the pregnancy stage to the labor stage and postnatal. So usually it might be a pregnant woman, or a woman who has already delivered, or a postnatal lady. So it could be any diagnosis, but when you are given the sheet, it gives you the title of whatever you are supposed to do in the beginning. So either the point you have a scenario of that, it tells you about your lady, what your lady is coming in with, your lady's complaints, your lady's introduction, her name, hospital number, everything. Then you also move on to, you are given a meals chart. So a meals chart is back in Ghana, we used to call something like a temperature chart. So it's a whole sheet which I'm going to show you, and it's blank. That is when you detail everything in it. So your observation you're going to take on the mother, that is what has to be detailed in your meals chart. So your first point, when you enter the room where you have the patient, you have the assessor, you have everybody, you're also going to have a table and a chair which has your whole meals chart there. Everything is structured. Now your assessor is going to introduce you to the whole environment, so you become used to where you are. You don't have any excuse to say that I didn't know where the gloves was, I didn't know where the hand washing, I'm supposed to do my hand washing. No, you are going to be introduced around. You need that orientation, and that is a standard way of practice. Even when we go to a clinical setting, you need to be orientated so you can know your way around and also help your patients in the right way. So you are orientated around, showed you where everything is. He or she's going to ask you, are you comfortable? Do you see where everything is? Are you okay to start? Now, if you say yes, she is now going to start the time, which is 20 minutes. And that is when you are going to start the whole process. So when you said yes, you are ready to start, and the time starts now, this is what you are supposed to do first. You need to assess the scene and make sure that the scene is safe. Where you are going to the patient is safe for you to approach. Now, these are some of the ways that you will say that a scene is not safe to approach. For example, here you go, you realize that there is a cowbell on the floor. You realize that there is a cup on the floor. you realize that there is a remote on the floor, a phone on the floor, water on the floor, anything that is not supposed to be on the floor aside your patient's slippers is not right, and that can also cause infection. So you just have to picture in mind, okay, I have a cobble on the floor, I have the spectacle of the patient on the floor. Is it safe for me to approach? No, it's not safe. What do I need to do? I need to make sure that the scene is safe. So I need to clear the whole area. If there's water spilled on the floor, you need to clean it because it can make you fall, or it can make the patient fall. Clean the surface area, make sure that the whole scene is safe for you to approach. If you have nothing there, then you have to verbalize to your examiner. You need to verbalize everything you are doing, because the examiner doesn't know what is in your mind. So even if you know that, okay, I'm supposed to put a temperature in patient's armpit, examiner doesn't know that you are supposed to, so verbalize it whilst you are doing everything. So this is how you do it. Assess the scene for safety, and this is what I will say. I'm approaching the patient, I'm assessing the scene for safety, and I can see the scene is safe to approach. I'm going to perform a hand hygiene. Now, when you are performing your hand hygiene, you can either use soap and water with a towel, or you're going to use a hand sanitizer. I prefer to use a hand sanitizer. So you pick your hand sanitizer. This is my hand sanitizer. So there's always going to be some. It's either pasted on the wall, or you just go and you just kind of press it. But let's say I have my hand sanitizer. It's in my palm. Okay. In my palm. You have to make sure it's around the whole part of your hand. And now you begin to say it. Because the examiner doesn't know you're doing palm to palm, you're doing skin to skin, whatever, all those words you have for the hand wash. But you need to verbalize each thing you are doing, because at the same time, one thing the examiner is doing, that the examiner is observing you. The examiner is typing whatever you are saying and any information which is good or which is wrong on the computer. So the examiner is doing two things at the same time. Should you not verbalize it, and should the examiner not watch you, because the examiner at the same time is listening to you, the examiner might know that, okay, you said you're going to do hand washing, but what did you do? You might have done your palm to palm, palm to back, all those things, but you didn't say it. So the examiner doesn't know you actually did it, and that can mark you down. So you do your rub your hand, palm to palm, palm to back, fingers will interlock, fingers will interlace. You do your thumb to thumb, you do your fingertips, you do your fingertips, you do your wrists, you do your wrists, and you leave it for 30 seconds to air dry. Now, the fact that they say leave it for 30 seconds doesn't mean you're going to actually leave it for 30 seconds, because you have 20 minutes. It may seem a lot until you realize that you are left with 5 minutes to finish. And that is not what we want to happen. So you're going to leave it for air dry. So you're verbalizing everything. By then, your hands would have already dried. So you're going to approach your patient now. And that is the next step. Okay, so before you approach a patient, you just need to introduce yourself, because the patient doesn't know you. You don't know the patient. You need to introduce yourself. And that is a way of having a rapport with the patient. So I go like, hello, my name is Anita. I'm one of the midwives who will be taking care of you today. Simple. Hello, my name is Agnes. I'm one of the midwives who will be taking care of you today. Hello, my name is Agatha. I'm one of the midwives on the day shift, and I will be taking care of you today. Hello, my name is Morrison. I'm one of the midwives, and today I will be taking care of you. This is a way to introduce yourself to the patient. Then you move on to asking the patient's name, date of birth, and hospital number. These are the patient details. Never forget. Always ask of these three things. Ask of patient's name, ask of patient's date of birth, ask of patient's hospital number. Now, if patient is in a wristband, usually a white wristband indicates patient's details and a red wristband indicates patient's allergies. So if you see a wristband on patient's arm, you can ask patient, kindly confirm your details for me. May I know your full name, please? Don't say, may I know your name. If you say, may I know your name, patient can say that I'm called Lily. But actually, patient is called Lilibet. And that is not patient's full name. So ask patient's full name. May I know your full name, please? So I'll say, hi, my name is Lilibet Mensah. Then she asks you date of birth. I'm going to ask you date of birth. You say that, okay, 15th June 1998. Then hospital number. Patient might not know hospital number. So at that point, you can say that I can see you are in a wristband. Are you happy for me to confirm your hospital number? Then you check. Not every patient is going to have the hospital number in mind. But if your patient has a hospital number in mind, fine. She's definitely going to say it to you. So you ask all these three things. Then you ask, hello, Lilibet, how would you like to be called? And that is when patient is going to tell you how she wants to be called. At the end of the day, you might realize that patient will say, okay, I'd like to be called Beth, or I like to be called Lily, or I like to be called Lee, or I like to be called Mensah. Now, since if you don't mention patient by how she likes to be called, then you are not granting patient's wishes. So patient's interest is not at heart. You need to make sure that you mention patient's name, how she likes to be called. So although her full name is Lilibet Mensah, but she likes to be called Beth or Lily or Lee. So just say however she wants to be called. So for example, she wants to be called Lily. Okay, hello Lily. I can see you are in an allergy band. If you see a red band, that indicates patient has allergies. So if you see that, then you can ask. Now, before you move on to allergy, considering the patient's details, if patient has a wristband and patient has verbalized her name, date of birth, tell patient, are you happy for me to confirm your details on your wristband? If you do not confirm the details of patient on the wristband, that is a total fail. Reason number one, this could be that patient's wristband's name is different from what patient said. So maybe a different nurse or different midwife approach patient, put a wristband on patient, but actually when you check the name, it's Elizabeth Sampson. This is different. Patient is saying she's called Lilibet Mensah. Now on the wristband is Elizabeth Sampson. That is wrong patient. Probably it could be the wrong patient, or it could be that the wrong patient details has been placed on patient wristband. So confirm that to make sure that you are having the right patient. So hello Lily, are you happy for me to confirm your details on your wristband? Sure, why not? Then you go ahead. You always need to seek permission before you touch your patient. Are you happy for me to touch you and check? Are you happy for me to check? If she says no, it's a no. If she says yes, fine. You check her name. Okay, you check with your details. I can see Lilibet Mensah, date of birth 15th June 1998, hospital number L00000. I can confirm I have the right patient with me today. This is how you say it. So now we're going to start from the very beginning. And this is how I'll approach the whole scenario. I approach the scene for safety. I can see the scene is safe to approach. I perform my hand hygiene. I start palm to palm, palm to back, fingers interlock, fingertips, thumb to thumb, wrist to wrist, and I leave it to air dry for 30 seconds. Hello, my name is Anita. I am one of the midwives who will be taking care of you today. May I know your full name and date of birth, please? And she's going to respond, hello, my name is Lilibet Mensah and my date of birth is 15th June 1998. Hello, Lilibet Mensah. How would you like to be called? Okay, I like to be called Lily. Okay, Lily. I can see you are in a wristband. Can I confirm your details on it, please? Sure, why not? So we have patient Lilibet Mensah. You have your notes with you because all those based on the table, you can take them. So you have your notes with you. Hello, Lilibeth Mensah. Date of birth 15 June 1998. Hospital number L000. I can confirm I have the right patient with me today. Done. How simple is this? So we're going to move on to the next point. And the next point is asking about allergies. Now, you can see that patients may be in a red allergy band or patients may not be in an allergy band. Either which, you need to ask patients, hello Lily, do you have any allergy you may know of? Lily might say that, okay, I'm allergic to penicillin, or I'm allergic to codeine, or I'm allergic to citrus fruit, or I'm allergic to egg. Whatever the allergy may be, you need to make sure that patient is in the red allergy band. Here lies the case. You approach your patient, you did ask of her allergy. She mentions to you she's allergic to penicillin. You realize patient is not in a red allergy band. You will need to verbalize to your examiner, okay, your communication is to the examiner and to the patient. So you need to verbalize to the patient, I can see that you will have no red allergy band on it. Are you happy for me to put one on you so that it can help any staff or any member of staff who approaches you to know your allergy, and make sure that once you are in the hospital with us, you are not giving any medication containing penicillin. If she agrees, you tell your examiner, I would like to put an allergy band on my patient before I continue. You find an allergy band, you put penicillin, you write penicillin on it. Ask patient, what happens when you take penicillin? You're like, okay, I vomit or it makes me nauseous. You write it, penicillin, nausea, and vomiting. You put it on patient wristband. Is that perfect? If patient is not having any allergy band on it and patient tells you that I have no known allergy, then that is totally fine. You move on. But if patient is having an allergy band and also she's telling you that yes, I'm allergic to penicillin and it makes me nauseous and also vomit, then definitely you are going to put an allergy band on. If you check and patient already has an allergy band, that's totally fine. You leave it, you confirm that yes, patient is allergic to penicillin and it makes her vomit and throw up. Are we good with this point? Let's move on to the next point. So after you've asked about the allergy, now you are now going to assess your patient. Ask her, what brought you here today? This is patient presenting complaint. Patient already has her notes which has been given to you, and her note is the scenario which they always give to us. So patient asks, you ask your patient, that what brings you here today? And patient is going to say all those stuffs in the British accent. Whether you understand it or not, you need to know it. So patient will tell you, okay, so I had sex last night, and after the sex, I woke up and I realized that I'm bleeding. It looks light pinkish. I'm having abdominal pain. It feels tender. It feels warm to touch. She's gonna tell you all those stuffs. Then you have that in mind. You can document it or you can keep it in mind. When she tells you that, then okay, this is what the patient has told you. You ask patients now, are you in pain? When a patient gives you her presenting complaint, ask her, are you in pain? Because if a patient is in pain, whatever thing you are going to do to the patient or whatever thing you're going to do for the patient, if the pain has not subsided, or if you have not told the patient that I'm going to do this, I'm going to give you this pain relief, I'm going to do this, I'm going to do that for you, patient may not be able to listen, and that can compromise your assessment you are doing for the patient. So ask, after patient has given you her presenting complaint, ask her, are you in pain? Patient will tell you, okay, yes, I'm in a bit of pain. Your next thing you're supposed to ask her, if I am to score your pain level from 0 to 10, where 10 is the maximum and 0 is the minimum. How would you like to give me your score? She might tell you, maybe a 5. Your next thing, you don't leave her alone. Ask her, would you want some pain relief? This comes in 2 ways. She might tell you, no, I think I'm fine. I can hold on to it. She might tell you, yeah, I think I might need some pain relief. If the patient tells you that, now, during the examination, you haven't seen your doctor, you can't just go and look for pain relief and give to the patient. So this is what you can tell the patient. I'm going to do a series of assessments on you and a series of observations on you. Right after that, I'll make sure I find the doctor to prescribe some pain relief for you. Are you happy for me to do that? She might tell you yes. Then you move on. OSCE, they don't trick you. Once you have been able to identify that patient might need a pain relief and you need to get that for the patient, and you have also made patients aware that you will get that for the patient once you are done with your assessment, they know that you are on the right path. So they won't go tricking you to tell you that, no, I need a pain relief now, get me the pain relief, and you'll be stranded. No, they won't trick you. They just want to know that you know whatever you are doing and you understand whatever you are doing. So once patients say, I'm in pain and I need pain relief, just know that you can just tell the patient that I'm going to do this series of assessments on you. If I am done, I am going to get the doctor to prescribe some pain relief, or if you are on any pain relief, I'm just going to get that at the right dose using the 5 hours and all those stuffs. So we move on to the next point again. So once you are done with the pain assessment level done, you're going to move on to review history. Now the review history is you are going to ask your patient. Now not ask your patient, but more of like confirm whatever is written in your notes. So the scenario bit you are given on the sheet of paper has patient medical history, past medical history, present medical history, obstetric history, family history, social history, medication history, any history you can think of that can help you. Like I said, they are not going to trick you. So they are going to give you the necessary history that can guide your work. Do we all understand this? And this is what we are supposed to review that history with your patient. So you need to make sure that all this history given is correct. So you tell your patient, there's a bit of history here in your notes I would like to review with you. Can you confirm that you had maybe hysterectomy? Sorry, not hysterectomy, because you can't be pregnant and have hysterectomy. Can you confirm that you have laparoscopy done in the year 2022? Yeah, I had laparoscopy done in the year 2022. That was beginning of the year in January, probably around the 20th. However, and that is when they will further give you more information that you can confirm. So she might tell you, yeah, I also had an IVF done, but it was a failed procedure, but we didn't give up. We went on to have another IVF done, and that is when we have our baby today. I also have 2 children. One is a boy, one is a girl, one is 8 years, one is blah blah blah. They're gonna tell you all those history. If they didn't say it, confirm with the patient that I can also see that you did this, you did that, or you have this, you have that. Can you confirm this with me, please? She's gonna tell you. If yes, she will. If no, she wouldn't. If it's a no, tell her that I can see that this is written and I'm gonna make that correction. Anything that you do with your patient which conflicts with your procedure or which conflicts with your notes, just tell the patient you would like to correct this mistake. Now you are done with the review of history. You are now going to start your process. I know it's long because you are going to ask yourself, oh my god, how am I going to finish this in 20 minutes and also document and give a handover to my patient? You are going to do it once you are able to practice for so long, and this is just a step-by-step process because I'm trying to go into details of what you are supposed to do. So it's going to look like a long video, but don't worry. Once you have your points written down, you know that this is how you're going to approach your patients, then you know what to do. You will realize that you're going to complete in 15 minutes, in 20 minutes. And I hope everybody completes in 20 minutes. I couldn't do it in my first time. I couldn't complete in the first 20 minutes. So my next time, I made sure I had really learned everything to make sure I could pass my exam. And I did it. And it was a success. So you can also do it. Okay, so now you need to explain your assessment to your patient after you have reviewed history. This is what you're going to do. You need to conduct a structured assessment. They're going to mark you on your organization skills, because now let's say you're going to do assessment on your patient. You do vaginal examination, you do your abdominal pain. Because it's not structured, you can forget. One, you are already anxious because you don't want to fail, you want to finish on time. Two, you might have felt intimidated by your examiner because you might think that, what if my examiner marks me down and all this kind of stuff. So you are already in that kind of space where the slightest mistake or the slightest question that your examiner can ask you can make you forget everything. So being structured and going according to can save you, help you cover all your assessment. So you tell your patient, I'm going to do a bit of assessment done on you, and this is what I'm going to do. I'm going to have your observations done, and your observations entails your temperature check, your blood pressure, your oxygen saturation, your breathing, that's your respiration. I'm going to move on to do your abdominal palpation, and I'm going to have a feel of baby. I'm going to measure your abdomen. I'm going to see baby's position, how baby is lying, baby's presentation, and baby's descent. Then you move on to vaginal examination. I'll be doing a vaginal examination done on you as well. Now, with the vaginal examination, you don't necessarily have to do a VE. If patient gave you a complaint that she is bleeding, you can ask that, are you in pad? Let's just hold on. When we get to the vaginal examination, I'll just take you through that. So you don't necessarily have to do a VE to know that, okay, I did a vaginal examination. Because not all vaginal examination or vaginal assessment will you need to do a VE or even need to pass a speculum. Some of them with just observation or with just whatever she says, you can already confirm that you have already done your vaginal assessment. So once you have explained all these things to your patients, you now ask your patient, are you happy for me to continue? If she says yes, that is when you can touch your patient. If she says no, you can't move on. But it's an examination, so at the end of the day, she's gonna say yes. So she wouldn't trick you to say no and make you complicated and put you in that uncomfortable spot. So once you've gained your consent, you need to stop whatever you are doing. That is, you put your sheet down, perform your hand hygiene once more, and you start. Usually, because it's an examination, I always like to wear my apron. Reason being that there might be a time I can forget. If you perform your hand hygiene, if you wear your gloves, if you wear your apron, even when it's not needed, you save yourself the trouble rather than not even wearing it at all, which can make you fail. And the examiners also give you reasons why you fail. They can tell you that you touched your patient without performing your hand hygiene, or you approach a patient performing an assessment which involved fluid without wearing your apron. You didn't follow the right PPE protocol, and that she has every right to mark you down. So before I even start with my observation, I'm just going to wear my apron, perform my hand hygiene, wear my gloves, and start the process. Do we understand? Or you can decide to do your observations first and then wear your apron and your gloves and move on to the abdominal palpation. You can't do an abdominal palpation without gloves. You can't do abdominal palpation without an apron. So you always need to make sure you have those bits on. You can do it before you start the whole assessment procedure, or you can do it when you are done with the maternal observation. Either way, where you can remember, always make sure that you need to have these 3 things of PPEs done in order for you to pass. Maternal observations involve checking the mother's blood pressure, checking the mother's pulse, checking the mother's respiration. That's your TPR. So I always have it in mind that, okay, I'm going to do a TPR, then I do a blood pressure and oxygen saturation. This is my way of helping me understand all this, because I don't want to skip anything. So I'm going to do my TPR. We all know that TPR, T stands for temperature, P stands for pulse, and R stands for respiration. So you do your TPR, you do your blood pressure, then you do your oxygen saturation. So when you're going to do your maternal observation, you are, like I said, every procedure needs to be verbalized. So this is what I'm going to do. I'm going to check your blood pressure. I'm going to put a cuff on your arm. I'm going to check, I'm going to measure the cuff. Make sure that you have the right cuff on, and the right cuff is supposed to measure at least 80% of your arm. So I put the right cuff on it, and the cuffs always have this kind of measurement. So I put the right cuff on it and measure your blood pressure. If it's a mannequin, you cannot hear any blood pressure. So your examiner is going to give you the information that, yes, blood pressure is 130/80, 120/70, 110/100. Then that means you need to be cautious of a patient's diastolic if a patient's diastolic is 100. But whatever assessment your examiner is going to give to you, that is what you're going to write. That is only if you have a mannequin. But if you have a patient, you are actually going to listen for the blood pressure and write it down. So if your examiner does not give you your answer to a blood pressure, ask yourself, what are you doing wrong? It could be that you just said that I'm going to do a blood pressure, but you didn't say what you're going to do. So you need to say that I'm going to check your blood pressure. Which arm would you prefer me to use? Okay, use the right arm. Okay, use the left arm. If patient gives you that, then that is when you use it. Now, another thing is, if a patient is in cannula and a patient's cannula is on the left hand, you can't do a blood pressure with the left hand. If a patient tells you that, I want you to do it on my left hand, you can let patients know that, okay, I can see you are in a cannula. It is not advisable for me to read your blood pressure whilst you have the cannula on, as it can cause blood to come through the cannula and also cause embolism. Are you happy for me to use your right arm? If patient is not in a cannula, then you move on and say that, okay, I'm happy to use it. Another way where you cannot use a place where a patient indicates is that patient will tell you that, okay, I like my right arm. You check the right arm, you realize the patient has rashes on the arm. We all know that we use cuff for different patients, although we're going to clean it, but patient has rash on the arm. You may not know if it's infection. You can let the patient know that I can see you have a bit of rash. Is it itchy? Are you happy for me to use the left arm just to prevent this, because the blood pressure add more pressure to your arm already? Definitely, when you give her a rationale and a reason why you are not going to do something, she's definitely going to accept. But if you assess the patient, patient says that, okay, I can use any of my arm, and you say that, okay, I can see that the left arm is clean, it has no rashes, you have no scar on it, you don't feel any pain around that place, I'm happy to use it. Put a cuff around your arm covering 80% of it at least, and I check your blood pressure. If it's a mannequin, your examiner will know that you know what you are doing. You have gone through the steps. You've assessed patient's arm. You've also made mention of the cuff, the right cuff for the patient. So the examiner is happy to give you the value if it's a mannequin. But if you don't give all these details, examiner is not going to give you your answer, because what have you done about the blood pressure that the assessor is to give you that value? So this is when people are like, I was standing there and I was nervous and no, it might have been that you didn't give much info as to how you're going to check your blood pressure. This goes for your temperature. I'm going to read your temperature for complete 60 seconds. When you say that, your examiner knows that, okay, we check temperature for complete 60 seconds. I'm happy to give you the value. If it's a mannequin, she's going to tell you the value. If it's respiration, I'm going to read your respiration for complete 60 seconds. Now with respiration, you don't tell patients that you read respiration. You can always do it when you are checking patient's pulse. So you tell patient that I'm going to do your pulse and your respiration, each for 60 seconds. But when you are reading patient's pulse, you don't tell the patient that I'm done with the pulse, so I'm going to read your respiration, because it makes patients kind of feel like, okay, she's going to check my respiration, so I need to be in the right breathing. No, you need patients off mind in order for you to have the right breathing for patient. So you can put your hand on patients I just want to say because I've forgotten. So you're going to check patient's pulse whilst you place your arm there to read it for complete 60 seconds. Still put your hand there, but this time check patient's chest movement and count that for complete 60 seconds. Once you're done, you say that, okay, I'm done with your pulse. I also took the opportunity to check your respiration by checking your chest movement for complete 60 seconds. And your examiner will say that, okay, you did this, you did that. I'm happy to give you the value for the pulse and the value for the respiration. If this is a mannequin, examiner gives you the values. If it's not a mannequin, you need to check these and know the answers. That is the whole thing about the whole process. So you've done all these TPRs and you are done, you are happy with your values. You either write it on your sheet, your rough sheet. I call it rough sheet, but it actually looks good. You might think that examiner is going to mark it, but they don't mark it. They only mark the meows chart. So you can write it on your rough sheet, or you can directly fill it on your meows chart. Either way, which you feel best. If you make a mistake on your meows chart, simply cancel it with a single line, do it again. If you don't want to make a mistake, you feel like you have enough time to do everything, simply write it on your sheet, take your time, plot it on your meows chart, make sure that you're using the right dots, the right arrows, the right marks on your meows chart. Is that perfect? So far, I hope everybody is understanding the whole step of the assessment stage and what you need to do. Okay, so you are done with your maternal observation. You tell your patient that I'm done with the maternal observation. I am happy, everything is normal. If things are not normal, if the blood pressure is a bit raised, you can tell your patient your blood pressure is a bit raised. I might check it in the next 30 minutes after I am done with everything. Is that all right? I'm gonna move on to your and do your abdominal palpation. Now, each part of the body I touch with the patient, I make sure that I perform my hand hygiene, because you were not doing a sterile procedure whereby you can say that you were in a sterile field. You are actually doing a clean procedure. You touch calf, you touch patient's arm, you touch staffs. You're not going to put that same hand on the abdomen. And that is where you can perform your hand hygiene again. Wear your gloves, wear your apron. Some examiners will be like, okay, move on. I can assume you've already performed your hand hygiene. Because once you have mentioned, they can acknowledge that you know what you're doing and you are actually going to do it. So you say that I'm going to perform my hand hygiene again, wear my apron and wear my gloves. I'll be with you shortly. She can tell you that assume you have done this, because you correctly mentioned that you were going to do it. And that is justifiable. So you perform your hand hygiene again, you wear your gloves, you wear your apron, and you now move on to the abdomen. You check, you give a whole visual of the abdomen just to make sure that there are no scars, there are no cesarean scars, there are no other scars. If there is a scar, ask patients, how did you get this scar? It could be that she said that she has had a previous section before. It could be that her previous babies might have been C-section. It could be that she has had a laparoscopy before. It could be she has had a major surgery on the abdomen before, and you may not know. So you find out about the scar. When you find out about the scar, if the patient has no scars, you have to verbalize. I'm assessing patient's abdomen. I can see there are no scars. I'm happy to move on. I'm going to have a feel of your abdomen. I'm going to see baby's presentation. I'm going to see baby's lie. I'm going to palpate for baby's back and check baby's heart rate. Usually you are given a peanut. You are not going to be given a Doppler. Some of you think, oh, I'm going to be given a Doppler. It's going to be poop. No. You're going to be given a peanut and you need to listen with a peanut. First, you check baby's presentation. When you are doing abdominal palpation, you need to check presentation. Make sure that baby is cephalic, baby is breech, baby is oblique, baby is transverse. Learn about all these presentation. And we know that if a balloting round ball is felt at the pelvis region, you can say that your presentation is cephalic. Because when you are feeling an abdomen, you always feel hard balls, two hard balls. One is the bum and one is the head. If one ballots, one does not ballot. One is the head, one is the bum. So the balloting ones are always the head. You palpated it, you realize that the balloting part is at the uppermost side. That's the epigastric region of your abdomen. You can see that, okay, this baby could be breech. You check that baby is on either the right side or the left side. You can say that this baby could be transverse. Baby might be down, however, baby might be in a diagonal position. You can say that baby is in the oblique position. Now, all these things is when you have an actual patient there, that is when you can feel it. If you have a mannequin, sometimes they put a baby in the mannequin where you can feel it. Some of them may not have a mannequin which has a pregnant abdomen there. It may be pregnant, but they may not have a baby there that you can feel the head. So the examiner will tell you that baby is oblique, baby is cephalic, baby is transverse, or baby is breech. If examiner does not say it, you need to verbalize what you are doing. If you give the right step that, okay, I'm going to have a feel of your abdomen, I'm feeling for a round balloting ball, then that is when the examiner will know that, okay, this is what you do. This is, you know your way around the whole process. So I am happy to give you the information. So you felt your baby's position. If it's a mannequin, they're going to tell you baby is cephalic. Maybe if you are saying it right, that this and this is what you are looking for when you are doing an abdominal palpation, examiner is going to give you the info if it's a mannequin. Now you're going to feel for fetal heart rate. Your FHR, you're going to have a peanut there. You're going to take your peanut and listen. When you are checking for a fetal heart rate, once you feel that beat on the baby, you compare with baby's wrist. You are using a mannequin, so we are not expecting you to feel a beat. If you say you feel a beat, that means you are telling lies. You are not being honest. And that is, you are. I don't want to go there. So if you are not feeling beat, please don't say you are feeling beat, because it's a mannequin. You can't feel beat with a mannequin. Examiner is going to give you the values. So simply put, just write, say your right info well, and examiner is going to give you the right details. So you are going to feel fetal heart rate. Okay, I'm going to feel your baby's heart rate. I felt the back of your baby on the left or on the right. You can also ask, I can feel that your baby's back is at this part or this part. Sometimes you can also interest the woman by telling her that usually what I look out for is a flat surface, a smooth surface. When I palpate your abdomen, I realize that some part is rough and some part is smooth. The rough part usually is the baby's extremities, that is the legs and the hands, and the smooth part is usually the baby's back. I could see that baby's back and is on the left or on the right. Or you can also interest her by asking, sometimes where do you normally feel your baby move, or where do you normally feel your baby kick? They'll say that, oh, sometimes I feel the baby kick on my right, sometimes I feel the baby kick on my left. So these are all bits of information that can help you to identify a baby's back. So when you locate a baby's back, you place your peanut on the abdomen and you listen. If you feel the beat, you now try to simultaneously check with the mother's pulse. A mother's pulse goes like boom, 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 boom. and a baby's pulse goes like boom, 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 boom. It's really fast. So usually when you are checking and you listen and you realize that you are getting a synchronization of pulse beating, you know that yes, this is the mother's pulse I am actually listening to. So you have to relocate your peanut to a point where the beat is not the same as the mother's pulse, and one is faster and one is slower. So usually the faster one is always the fetal heart rate. But since you've already checked your maternal pulse, someone may ask, what if the maternal pulse is faster? You've already done maternal observation. You know that mother's pulse is 80, and 80 pulse does not go pum, 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 pum. It actually goes the pum, pum, pum. So definitely you can't say that, oh, what if I was checking and mother's pulse was faster? No, you've already done your observation, so you know the mother's pulse, and you know that mother's pulse was not fast. So definitely the faster one you are hearing is the baby's heart rate. Then you listen to that for 60 seconds. So you tell the examiner, I am listening to the fetal heart rate for complete 60 seconds, simultaneously checking it with the mother's pulse. Then you count for 60 seconds. If it's a mannequin, definitely she's going to give you the values, and she's going to tell you, okay, it is 60, or it is, if it's 60, then your baby might die. It is probably 140 or 130 or 120. A normal range is always within a 110 to 160 in the UK standard. If in your facility back in your country is 120 to 140, don't bring that here. Have the UK standard in mind, because at the end of the day, you are getting a UK license and you are going to practice with the UK standard, with the NMC code of conduct and practices. So always make sure that whatever you are doing is abiding the UK standard of procedure, and that is what is going to gain your score. It's all right. So now you are done with your abdominal examination. You have palpated, you have gotten your values and all the important bits and bits. Ask mother. The examination, this is where we are going to move on to the vaginal examination. This is what interests me the most. So mother is a term vaginal bleeding. There's one part I didn't include in the abdominal palpations. You need to feel for contraction. You need to feel for contraction of the mother's abdominal palpation when you're doing mother's abdominal palpation. If you feel for contraction, you can see that, okay, mother might be in labor or not. If you don't get any contraction, then your differential diagnosis might not be a labor. So when you do your contraction as well, when you're doing the mother's abdominal palpation, it's just going to give you an idea of whatever that is going on. Then you move on to the vaginal examination. Before you move on to your vaginal examination, ask the woman, are you having any vaginal loss? She will tell you yes or no. If it's a no, you don't need to do any VE. You don't need to expose her genitalia and check what is there. No. If it's a yes, ask her, what is the color? So if she's saying that it's light pink, watery, or is deep red, or is dark brown, or is yellowish, or is milky, all those bits of information she's going to give you. If mother is in labor, if mother is having an infection, or mother is having an APH. And APH is antepartum hemorrhage. So I'm not going to go in depth what antepartum hemorrhage is. We are midwife, we all know what an antepartum hemorrhage is. So I'm not going to go into details what that is. Just to let you know that the kind of vaginal loss your patient is having, or the kind of vaginal loss your patient is explaining to you, that is going to give you a bit of an idea what this might mean. Now, if she tells you that she's having an a vaginal loss, you can ask her that, are you happy for me to check? Ask her, are you in a sanitary pad? If she tells you that I am in a sanitary pad, ask her, before coming to the unit here, did you change your sanitary pad before coming? She might tell you that yes. You can even tell that, yeah, I changed it about 3 times, and it is light pink, watery, almost like water. Then you know that mother might have broken her waters. Her waters are broken. She might have lost her liquor. So definitely you can see that, okay, all those are presumptions you have in mind, but you don't tell her that your waters are broken. What if it's not waters that are broken? Her description is wrong. So if she has changed her sanitary pads, her sanitary pads or her sanitary towels, you ask her, are you currently in a sanitary towel? Are you happy for me to have a look at what is in it? If you check, okay, this look dark brown, this is an old blood. This look bright red, fresh blood, so active bleeding is ongoing. Or this look pinkish and it looks watery and is soaked. This looks like your waters might have broken. So I could, looking at her gestation, looking at her waters being broken, you can see that, okay, this is a premature rupture of membrane, or this could actually be an early labor. It's all dependent on mother's gestation. Or you can say that, okay, this and that. So you are done with all your examination. You've done your maternal observations, you've done your abdominal palpation, you've done your vaginal loss assessment, and you've written all those bits, and you are happy with whatever is written. Now you tell all your findings to the mother. You tell her that, looking at my whole assessment done on you, I would like to say that you could probably be in early labor. So these are your differential diagnosis. You probably be in early labor, or I could suspect an emergent preeclampsia, or I could suspect UTI, depending on the details that you have. If you have all these bits of information, you tell your woman, this is what I'm going to do. Now your next bit of assessment, which I might not have added, that is your urinalysis. There is always a urine sample there. It's not actually a urine, but it looks like urine and is there. So you need to perform your urinalysis. Usually people fail at this assessment station. Your urinalysis, you need to be in your apron, you perform your hand hygiene, tell that I can see that you have brought urine sample today. Are you happy for me to test? You dip in your urine. You now explain to your this part of urinalysis, you have to do it in the presence of the examiner. So you inform the examiner, I'm going to perform the urinalysis. Be in front, make sure that the examination, the urine sample you have, your urinalysis you're going to do, the examiner can see you doing it. You don't do it behind the examiner or whatever. So you perform it, and that is, you open your urine, you keep it on the table, you check your dipstick bottle, recite it out. Now I have my urine strip here. Date expiration date is June 2028. I can confirm that this is valid to use. You open it, you take your dipstick. Sorry, that's my baby. You take your dipstick, then you dip it in. I dip it in the urine and leave it to read for at least complete 60 seconds. You don't go about saying 120 seconds or no. Give a standard value. Complete 60 seconds. Sorry, at least complete 60 seconds, following the guidelines of the manufacturer or following manufacturer's guideline. Then you read it. Always read it for you. For some reason, I don't know whether it's a chemical produced urine, but it's just going to give you, some of them are going to change colors depending on what they want you to do. So you need to read it out with your bottle. The bottle always have colors indications. So don't go and say that protein is negative, sugar is negative, so I'm done. No, read everything out. Compare. Ketones, negative, or probably ketones is +1, or ketones is trace. Blood is there. You have your leukocytes, you have your protein, you have your sugar, you have your bilirubin, you have all those details that is in bit. So you read all those things out and say if it's negative or if it's positive. Some of them your examiner will tell you, if they don't have the chemically manufactured urine where it can read, they'll just tell you that maybe your leukocyte is 3+, or maybe your leukocyte is negative. where they find it interesting that they want you to document a bit of information, they are going to give it to you. That is only when the urine given to you does not change any color when you put in your sample. If it does, they're going to leave it for you to give them the value. If it doesn't, they are going to give it to you. So depending on whatever case you go to meet, if it doesn't read or if it doesn't change color, you can inform your examiner to give you the values because it doesn't change. You can't formulate your, if you presume anything and it is wrong, and actually your examiner was expecting you to ask her which the value was actually maybe glucose of 4 pluses and you were saying leukocyte of 2 pluses, you have formulated yours and that is wrong, and that can make you fail your examination because you're going to indicate it on your Meows chart where there's an indication of protein. So if you indicate it and actually there is a protein of 2 pluses, but you are saying there's a glucose, then that means that the protein section, when you are filling your Meows chart, is going to be a 0. And that might alter your score for the Meows chart, which automatically gives you a fail. Despite all the good things you have done, all the procedures you might have done, your Meows chart can actually cause a fail if you make a mistake. Your analysis has to be perfect. You do it. Once you are done, tell them that you dispose of your apron and your gloves in your clinical bin or in your infectious bin. That is usually the yellow bin. When you dispose it, you perform your hand hygiene again. Then you give all your findings to your patient. Let your patient know that, okay, this and this are my findings. I can say that you might probably be an early labor, or you might probably have a uterine tract infection, or you might probably have an emerging preeclampsia. Now, I'm going to take your urine to the lab and have a further MSU done on you. Have an MSU done on you. So that's when it's going to detect all those beds, urine, the infections, and all those cultures and stuffs. So once you are done with your assessment, you quickly go to your Meows chart. You need to fill in everything. Make sure that you fill in patient details. You write today's date. Usually the Meows chart has frequency observation. Make sure you fill your frequency observations. You fill your Meows chart. You give your score. You now move to the back and check, you map your score to your scenarios there, so your criteria there. So if you check your score and you are getting a 2 yellow and a 0 red, you check it, you realize that 2 yellow, you are supposed to observe your mother hourly. You inform, you escalate to your ward manager, you inform your obstetrician to come and have a look at the patient, do all those assessment review in the next 30 minutes, all those bits there. Then you now move on to your handover to your examiner. You say, examiner, I am done with my assessment and I would like to hand over. My Meows score is, I had 2 yellows, 0 red, and therefore this is what I will do. You will read those things given at the back of the Meows chart, mapping to your score. If it's 2, or if it's 3, or if it's 4, mapping to your score. If you finish with that, then you also ask that my differential diagnosis is this, that. Always give at least 2 differential diagnoses. If you want to be safe, just give a 3 differential diagnosis. Now, a differential diagnosis doesn't necessarily say that you have actually diagnosed your patient. It's just a guideline to help you plan your care and to help you know what you're supposed to do. So when diagnosing a patient doesn't mean that you have actually given an actual diagnosis to the patient, so the examiner is going to mark you down. So give a differential diagnosis where you feel like this might be correct. Okay, so I hope I have digested everything under the assessment station. If you have any question whatsoever, I am happy to answer you in the comment section below. So do not hesitate to ask me, or I am ready to help, because the midwifery OSCE can be really tricky, can be so confusing, but at the end of the day, if you have it all done, you know that you are good and ready to go. Thank you so much. I need to attend to my baby now as she needs me, and I hope you've had the best of it all. See you, and the next time we might talk about the planning station. Bye.